All right, let's get going with the next chapter that we have in our book for RN26. This chapter is talking about heart and failure. So let's look at some of the reasons why the heart fails, some of the underlying problems that a lot of the patients that end up in heart failure have, and what the treatments and approaches that we utilize both within the acute or critical care setting, mostly acute, and then outside of the hospital as well. Some new and upcoming knowledge that we may have that we may use, for patients that have heart failure. So without further ado, we do have a couple of objectives that we need to really focus on. The only one that I'm really not going to be going into, I think I have one slide. There was like 20 slides about all the way at the bottom where it says describe cardiac transplantation. Talking about organ transplant is a lecture in of itself, and so I took out most of the heart transplant slides. I think I left one in with a couple of basic pointers that I'll go over. But this lecture is not about heart transplant, so I took most of those slides out. We're going to be focusing on understanding the pathophysiology of heart failure. You will be expected to know the difference between systolic and diastolic. And I created some pretty good slides in here to try to demonstrate the concept behind the difference that exists between one and the other. We're going to look at the compensatory mechanisms. A lot of the slides that are on in this presentation, I organized between what we call acute decompensated heart failure and chronic heart failure. That sounds like very fancy things. We love to give complicated names. Really, the difference between ADHF and HF and chronic heart failure, one is acute, one is chronic. So really, when you see the word ADHF or acute decompensated heart failure, just think it's an acute episode of heart failure. So we need to really care for it promptly, quickly, sooner. And the chronic heart failure is just the chronic manifestation of the heart failing. So you will need to know the difference between acute heart failure and chronic heart failure and what type of treatments we want for both of them. And then the nursing and care and interventions that as nurses we need to be aware about for both the acute heart failure and the chronic heart failure. And then we'll talk a little bit about interprofessional care and whatnot. And at the end, I'll give you some extra information that I think is important to know as well. Because as healthcare professionals, we work with evidence, and I'm bringing forth some evidence here to assist your understanding and what other alternative approaches we can use for heart failure as well. So heart failure is pretty much one way of thinking about it is it's the heart starting to fail. But we have to remember that even though the heart is treated as a pump, and it does with its ventricles push blood forward in a sense, it's much more than just a pump. It's an electrical device, it's a mechanism, it's a muscle. It has at the cellular level mitochondria, ATP, all energy production. So we need to stop thinking about the heart as a pump, and that's it. It's quite a complicated organ, and for many reasons other than just the fact that it's a muscle or a pump, it can fail. It can fail from an electrical perspective. The muscles can fail, calcium, potassium being involved, and the muscles can get weak, the cardiac output, then we have the left side, the right side. So we have to take a step back and go into our pathophysiology and understanding of how the heart is built and what part of the body is going into the heart, what part of the body is the heart pumping to. Right? So if you think about in really common, simple, very basic terms, why the heart fails or what heart failure means, it's basically when the heart is not able to meet the demands of the body. That's really, in a nutshell, heart failure. The heart is unable to meet the demands of the body. Now go figure, the reasons why a heart might be unable to meet the demands of the body are multitude. There's a large list of them, and we'll cover some of the most essential, pertinent ones that we need to know. When the heart is unable to meet the demands of the body, tissues will no longer get the oxygen needed. And what's inside oxygen that's important? Well, what's inside blood that's important, right? Inside blood, we have oxygen, but we also have nutrients. And so if the heart is unable to meet the demands of the body, part of it is nutrients won't be delivered appropriately. Likewise, oxygen won't be delivered. And so hypoxia, ischemia, a lot of other problems can happen. Back pressure will start to occur, which end up leading to edema, which could happen in multiple areas, lungs, liver, kidneys, the digestive tract, and quite a few other areas. So third spacing happens, pleural effusion as well, right? And then with heart failure, the body's detoxification processes, sorry, I should be changing that word. I should be putting the body's elimination organs, right? And there's quite a few of them, but in this case, kidneys and liver, together with the lungs as well, in a sense, play a major, they'll be compromised when the heart starts to fail. In other words, another way of saying that is that with altered perfusion, because when the heart fails and is unable to meet the demand of the body, that means that cardiac output drops, and naturally perfusion to your toes, your fingers, your brain, and to the organs will drop as well. And that means that perfusion will not be getting as well or properly to the kidneys and to the liver. And we know that these are two important organs of elimination. And so elimination will not be possible. They're the same thing, really. We have to think about, we don't use in the nursing world the word detoxification. When we talk with our doctors in allopathic medicines, we use the word elimination and their elimination organs, but really they work to detoxify and help the body not have all of these buildups of that can become toxic to the body. So I like the word detoxification as well as the organs of elimination, because it really shows both of them as proper and appropriate to utilize. I threw this in at the beginning. There's a few slides later down. I put this in, I sort of tried to summarize the NYHA functional classes. So how do we classify heart failure? And there's two forms of classifications. This is one key. One, we'll talk about the other one. This is one that is commonly used. So if somebody has a New York Heart Association functional class 1 heart failure, that's the person has no physical limitations. They might still be able to go out and jog a little bit or walk and ambulate and go to the movies. Class 2 means that they're starting to have symptoms with a little bit of exertion. Class 3 is symptomatic with mild exertion, and class 4, they have symptoms at rest. So you need to know the differentiations between these. Class 4 is obviously more severe than class 1. Okay, so we need to keep that in mind. And these are basically just different levels of severity, right? And it's important to know this. I think I should be saying is that the functional class will determine the level of intervention that the patient will be needing. That's very important to keep in mind. So again, considering that heart failure is very complex clinical syndrome, because that's what it is, we know that it's the heart's inability to meet the body's demand, but it's really a conglomeration of a lot of other problems that a patient may have that lead to having the heart failing. And again, the important thing is to remember that if that happens, this failure happens, the heart will not be able to provide sufficient blood, including oxygen and nutrients, to the tissues and the organs. And it's a major health problem. In fact, 650,000 people in this country die every year of heart problems, which include myocardial infarction, coronary artery disease, and stroke problems as well, mostly ischemic stroke. So heart failure is also part of that large number of people that are dying. And so we need to understand, initially, I have another slide that I think will clarify a little bit better, but when you look at diastolic and systolic, one way to look at it is that if you have diastolic heart failure or dysfunction or a diastolic problem, it's going to be a defect or a problem with ventricular filling, right? Whereas a systolic problem is going to be more of a ventricular ejection. Both of them are really very important manifestations of heart failure, but there's a significant difference between the heart being able to fill up with the blood that it then will need to eject, or the heart being unable to fill up with the blood that it needs to eject, as opposed to a systolic heart failure problem, which is an actual problem of the ventricle not being able to eject properly. Now, you can imagine if you have a diastolic and you're not filling properly, then obviously the ejection is going to be minimally effective because you're not getting that same amount of blood, and vice versa. If you're not able to eject properly, then as much as your ability to bring blood into the heart is occurring, it'll start to back up and create problems downstream elsewhere of the body. Now, for heart failure, you really need to become familiar with the word EF, ejection fraction. You'll hear it a lot talked about in the hospital. A normal ejection fraction, I believe, is above 60. In fact, most healthy people might have a 70 or 80%. It's not like oxygen saturation where we want you to be at 90 to above, nothing like that. And then problems start to happen when your ejection fraction are below 40, below 30. And then severe heart failure, a lot of times patients who are on methamphetamines and other drugs of abuse, IV drug abuse as well, may end up having ejection fractions of 10, 11, 12, 15%. And at that point, they're severely ill. And then the how we treat them is going to be very, very different. And so just remember that the amount of blood that pumped by the left ventricle with each heartbeat. So every heartbeat is going to have X amount of blood being pumped outward. With each heartbeat, one heartbeat pumps out X amount of blood. That is your ejection fraction with one heartbeat. Okay, so you need to know that. Now, heart failure can also be broken down into, and this is important. You will need to know this, and I have a slide. I'm just going to tell you ahead of time before we get to that slide, so you can keep it in mind. There's something that we call heart failure with reduced EF, reduced ejection fraction, and heart failure with preserved ejection fraction. And again, when you see that heart failure with reduced EF as opposed to heart failure with preserved EF, meaning that the ejection fraction is not affected, again, we need to come back and think about it from a systolic and a diastolic heart failure perspective. Okay, so keep that in mind. Very important to distinguish between systolic and diastolic. And when we get into talking about systolic and diastolic, knowing whether the ejection fraction is being reduced or preserved and not reduced is very important to know the distinction between in terms of heart failure. I found these definitions and I thought they were a little bit more straightforward to express what the difference is. So systolic heart failure is when the heart cannot contract, eject with adequate force to eject the blood. So systolic is about pushing the blood forward, ejecting it, right? That's why we look at ejection fraction, especially with systolic heart failure. Diastolic heart failure is when the heart muscle has impaired relaxation. When the heart is unable to relax properly, that is going to prevent enough blood from coming back into the heart before the ejection happens. Okay? If this is not clear in your mind, pause. Hey, E.T. Whoop. Sorry, people. My cats are going after each other. E.T. And so please pause this, go back and look at it, and try to understand the difference between both of these, because it's very, very important to understand, okay? Heart failure in general is always going to be associated with cardiovascular problems, cardiovascular disease. So anybody who has cardiovascular problems, could be coronary artery disease, could have been a history of an MI, any related bundle branch block, any heart problem in general, which we sort of create a large general conceptual term of, such as CVD or even coronary artery disease, with a lot of the plaque buildup, and which leads to a lot of the problems that we have in the hospital today, MI, stroke, and so on. Well, any of the patients that have those conditions, MI, stroke-like symptoms, hyperlipidemia, hypertension, hypothyroidism including, they tend to have a higher incidence and higher prevalence of heart failure. And that makes sense because at the cellular level, how the cells function, they don't distinguish between whether it's CVD, hypertension, hypothyroid. We've created these names sort of to understand what's going on. Aging population, men in their 60s, a little bit more than females perhaps. And it's not only one of the most expensive problems, cardiac problems in general are the #1 killers in our country, but therefore they're one of the biggest burden on our society and on the taxpayers' pocket. And so some people think of it as primarily heart failure, primarily as a disease of older adults. And in fact, I think it's thought that heart failure is one of the most common reasons for adults, men or women above 65, are admitted into the hospital. And so this is good to catch early, to treat early, because once it starts getting into later stages, the prognosis tends to be lower, not as good. So there's primary and secondary, and we'll see that in the next slide or two. Primary risk factors for heart failure are, generally speaking, two of them: hypertension and coronary artery disease, as you can see in this slide. And hypertension is a modifiable risk factor. We should, be treating it aggressively as we can with lifestyle treatments, and of course, alcohol, tobacco, exercise, diet, nutrients. And if that type of aggressive therapy doesn't work, then maybe more drug therapy as well. So long-term treatment of hypertension can actually help reduce heart failure significantly. So treating hypertension is important for heart failure patients, and likewise other comorbidities, which include things like metabolic syndrome X, which is, of course, diabetes, tobacco use, vascular problems, peripheral vascular disease, and so on and so forth. So there's quite a few other comorbidities, but generally speaking, hypertension and coronary artery disease are the two biggest primary risk factors. Now, etiology. So where does heart failure come from? What causes heart failure? And so the one good way to understand that is to try to understand what heart failure means. And since we already know the general description, it's the heart's inability to meet the body's demand of providing blood, which includes oxygen and nutrients. That's one way of looking at it. But another way, when we go into the little details, is to understand that the heart has certain actions that take place in and around the heart that will be affected. So we know that cardiac output is extremely important to perfuse the body. So if cardiac output is affected, that whatever the reason that cardiac output is being affected, that's one of the reasons the patient is getting heart failure. And we know that cardiac output depends on preload, right? The relaxation. If anything affects preload, that would be the etiology of the heart failure. We also know that afterload tends to have to happen. It occurs, and even the systemic vascular resistance that the heart works against, such as diabetes and having thick bloods because sugars are not well managed, or a tobacco smoker who drinks alcohol, doesn't exercise, and has a lot of lipid buildup because of coronary artery disease, and there's blockage in the tubes, and on top of that he's diabetic and metabolic syndrome, so the heart is now really working against very viscous blood, very narrow arteries because they smoke and nicotine is a vasoconstrictor. So the afterload is really affected. That is the problem and the etiology of heart failure. If something is affecting myocardial contractility, that is the etiology of it. And finally, heart rate. So if you think about the heart as preload, afterload, contractility, and heart rate, and cardiac output, and basically cardiac output is preload, afterload, and the contractility. All of these factors. So if they take a drug that drops their heart rate, it could affect them in terms of causing heart failure. If it affects their heart rate in tachycardia or bradycardia, it doesn't matter if that cause of tachycardia or bradycardia. So really, so in other words, again, remember what I said earlier about heart failure. It's a syndrome. There's not one cause, there's multiple causes, and one way of understanding it is to try to understand how the heart works in the first place. And that's why mechanisms that regulate cardiac output are extremely, extremely important. So primary causes we know: lifestyle, coronary artery disease, hypertension, so on and so forth. We've talked about that, right? The two primary ones are what? Hypertension and coronary artery disease. Two of the primary problems that lead eventually to heart failure. So let's treat those early on and we may prevent heart failure. Let's look at precipitating factors. What are precipitating factors? Again, any condition that increases the workload of the ventricles, that again ultimately is going to result in decreased cardiac function or decreased cardiac output. So what are some of the examples that we could think? My God, there's a lot of them. If they have trauma, or if they have any problem with hypervolemia, they're going to have too much fluid, hypervolemia, too much volume. That's going to increase what? Preload, which is going to increase the workload. If they have hypovolemia, that's going to do the exact opposite. If they have nutritional deficiencies, that's going to decrease the ability of the heart to function properly. That increases workload. If they have pulmonary embolism, that increases the workload to pump blood in the lungs. If they have, let's say, anemia is a good example. What happens with anemia? They have decreased oxygen supply, right? And that increases the workload of the heart and the ability to meet the demand. So maybe the heart's pumping properly, right? There's enough blood getting to the organs, but if there's not enough oxygen within the body because of an anemia occurring, similar effects to a decrease in cardiac output are going to take place. It's a lack of oxygen supply, not because the heart necessarily or the cardiac output, as in terms of a mechanistic approach, is occurring in the heart, but anemia is happening and there's not enough oxygen due to that anemia in the blood. That leads to similar effects. Hypoxemia, no different, right? Except in one case it's the heart actually failing. In this case, anemia could lead to it. Infection. What happens with patients that have infection? The body has to fight the infection. So what do you think? Increase oxygen demand. So we got to treat the infection, because if they are infected, they're going to need a lot of that oxygen that's already in a low supply. So infection is a big problem with heart failure patients, right? There's a lot of other problems. Hypothyroidism is known to be a problem. A lot of times if people in outpatient settings their thyroid is treated properly, it can tremendously help them. Dr. Mark Starr has written a great book about hypothyroidism as one of the major pandemics in our nation today. I highly recommend if you can get your hands on his book. Really a great read. Dysrhythmias or arrhythmias, they decrease cardiac output and increase workload. Bacterial endocarditis, right, which is an infection, is going to also increase the workload. Obstructive sleep apnea, same thing, not enough oxygenation happening. You get the point. Any of these problems that are not the primary causes are going to be causes that are precipitating or leading to. So therefore you get it. There's a lot of different etiologies to heart failure. Now, left-sided heart failure is the most common form of heart failure. And it results either from the inability of the left ventricle to empty or to eject adequately during systole, again, the ejection fraction systole, or it's because there's a lack of ability of filling adequately during diastole. Okay, so again, this is important, and we have slides for each one of these, including the mixed. So left heart-sided failure results from left ventricular dysfunction. That's why it's called left-sided heart failure. And when that happens, it prevents normal flow of blood forward, pushing forward, that ejection. And that is going to cause blood to back up into the left atrium and ultimately into the pulmonary arteries. So with patients of this nature, we have to monitor their lungs as well to make sure that they're not getting increased pulmonary pressure or fluid buildup and whatnot. So assessment on these patients includes obviously listening to their lungs carefully, because we want to make sure that they're not going into pulmonary congestion or edema as well. So it's very important. And then we have a slide that differentiates heart failure between wet and dry. And you'll get the point when we get to that slide that wet is really about more of a congestion, fluid buildup problem. So what is the pathophysiology for the systolic? And notice at the top of this slide, at the top, when it says HFrEF, that is very different from if that R were a P, HFpEF. In this case, this slide, we're talking about heart failure with reduced ejection fraction. Remember, ejection fraction is one heartbeat and the ability to eject how much blood in one pump of the heart, one beat of the heart. So with heart failure that has reduced ejection failure, the pathophysiology is again an inability to eject or push the blood forward, right? Which is decreased left ventricular ejection fraction, and it's caused by either increased afterload, the systemic vascular resistance that the heart is working against, impaired contractile function, problem of the muscle of the heart, or mechanical abnormalities. So those are the general problems. And so when we say impaired contractile function, think myocardial infarction, okay? When you think increased afterload, think hypertension, or think diabetes with thick blood, or a smoker with smaller vessels because of the vasoconstriction, increased afterload, okay? So I'm hoping that this is starting to get into your head slowly, right? And you still have semester 3 and 4 to go through it, and you'll get this in much more detail. Cardiomyopathy is really talking about, or like mechanical abnormalities. That's valvular heart problems, and we've already covered that in previous classes. So diastolic, we just talked in the previous one about systolic heart failure. Diastolic, notice that it's HFpEF because the ejection fraction is generally speaking preserved, okay? And what is HFpEF? Or in other words, I could be asking, what is diastolic heart failure? Right? You get the point? If I ask what's diastolic heart failure, it's no different than asking what is a heart failure with preserved ejection fraction. And it's the inability of the ventricles to relax and fill during diastole. And interestingly enough, they say that 5 out of every 10 or 50% of patients that have heart failure are going to have a preserved ejection fraction. Their ejection fraction may not be at all affected. Whoops. Let me get back here. What happened there? Okay. And so risk factors include older age. Female tend to be more affected with the HFpEF or diastolic failure, diabetes and obesity. So in a lot of the metabolic syndrome X type patients, now it could build to a point where a diabetic or a metabolic patient ends up having a low ejection fraction, but at that point it would be a late symptom, a late problem. If we catch it early enough, we can stop it. So generally speaking, in diastolic failure or heart failure with preserved ejection fraction, the left ventricle is generally functional, but it may start to, because of some compensatory mechanisms that we're going to talk about, start to become stiff and non-compliant. And so we need to keep that in mind as well. And ultimately, the end result or the end product of diastolic failure is no different from the systolic failure. Ultimately, it's pulmonary congestion. Either way, okay? How do we diagnose HFpEF versus HFrEF? And really, the signs and symptoms of heart failure. So we look for signs and symptoms, swollen edema, lungs, things of that nature. So it's kind of hard to actually diagnose and assess for. We look for the diastolic specifically. We look for normal ejection fraction, tends to indicate more of a diastolic problem, and evidence that the left ventricular diastolic dysfunction is starting to occur, and you can do that with cardiac catheterization or an echocardiograph, which is one of the key things. Echocardiogram, when you think heart failure, you need to think basically two things from a diagnostic perspective. One is an echocardiograph, and two is we want to look at their BNP, and we'll get into that when the time comes. But I just wanted you to get it ahead of time. So so let's go back. So the result of the left ventricular hypertrophy, which is a compensatory, the heart starts to work harder, can happen again from a lot of the things we said can cause heart failure, hypertension, diabetes, obesity, and at the end, it's the same result as systolic. They may differentiate in the beginning when the patients have it. Hopefully, we can catch it at that point. But at the end, it's the same problem. Okay. All right. So mixed heart failure, or mixed systolic and diastolic heart failure, is really seen in conditions where you have more of a dilated condition. And how to define what a dilated cardiomyopathy is? It's where the systolic function is not working that well, and on top of that systolic function not working well, it's compromised by a diastolic problem, again, which is the inability to relax. And you want to think of dilated ventricles, even the left ventricle wall. Even when it starts to become dilated, it's in the beginning it starts to open up, dilatation, but that can lead to an inability to relax, and it's going to lead to that diastolic problem as well. So it's a mix. And from a nursing perspective, it's very rare for us to really start to look at the distinctions, but it's good to know what they mean, because we do have a patient that has systolic versus diastolic heart failure, treatments, interventions, and even assessments may differ a little bit, and we'll get to that when we get into the nursing interventions. So the pathophysiology for right-sided heart failure, again, is when the right ventricle is failing to pump, right? No different from the left ventricle. When the right ventricle is having failure, then it's not going to be able to pump forward. So ejection fraction is probably going to be affected as well. So we do need to think that when the right ventricle fails, though, fluid is going to back up into the venous system, which is important to know. And why? Because that movement of fluid into the tissues or the organs are going to go downstream and end up causing peripheral edema, abdominal ascites, think liver, because that's right goes back to the body. Right is going to go, so hepatomegaly, the spleen sometimes could be enlarged, but generally the liver more so, and even JVD, or jugular venous distension. So with right-sided heart failure, you want to think of JVD as well. And so this is a really interesting point. What do you guys think the most common cause of right-sided heart failure is? Well, left-sided heart failure, right? Because when the left ventricle fails, fluid is going to back up where? As opposed to the venous system, into the pulmonary system. And that's going to increase pressures in the lungs. And so now the right ventricle is going to have to work harder to push blood to the pulmonary system. And basically over time, the increased workload weakens the right ventricle, and ultimately the right ventricle will fail. as well. Now we do have to be careful because there are other reasons why right ventricle failure occurs, and that could be infarction, like an MI. It could be pulmonary embolism, a PE could lodge. Remember, thrombus converts to an embolism, travels and it lodges in the pulmonary artery, and that causes a major problem. And cor pulmonale as well is one very classic sign and symptom of that could lead to right heart failure. And again, that has to do with dilation and hypertrophy from pulmonary disease, from problems of the lungs, chronic problems of the lung. So chronic problems of the lungs can also lead to having right-sided heart failure as well. So now we're not talking about systolic, diastolic, or mixed, but just in general, a patient with ventricular failure of any type, right, left, right, mixed, doesn't matter, is going to ultimately have low blood pressure, low cardiac output, and as I said about the elimination organs like the kidneys, poor renal perfusion, even poor hepatic perfusion as well. So, and heart failure can also have an abrupt onset, like an acute myocardial infarction or a heart attack. It can also have a slow progressive change over time. And then so the body is always going to have to, if the body is struggling to meet the perfusion, it's going to have to, the body is going to go into compensatory responses like enlarging of the heart or beating faster of the heart. Why? Because it has to maintain that adequate cardiac output. And so what do you guys think the main compensatory mechanisms are going to be? So you'll hear this slide, this lecture use the word neurohormonal responses, but that's really the renin-angiotensin aldosterone system, the RAS, and the sympathetic nervous system as well. Those are one of the major causes, the RAS and the sympathetic nervous system. But then you also have ventricular dilation and ventricular hypertrophy. So the heart may start to dilate in order to help more, because if there's not enough going out to perfuse, the heart's gonna say, well, let me not only enlarge the heart up, but let me dilate more to allow more blood to come in, because maybe if we allow more blood in, I'll be able to eject more blood out and perfuse the body better. So dilation is, together with hypertrophy of the heart, a manifestation or a compensatory mechanism. Sorry. So those are the general ones that we're going to be seeing. So of the three that we mentioned, well, two or three, the renin-angiotensin system is really a system that tries to keep homeostasis, and it really works tremendously in trying to keep blood control and fluid and electrolyte imbalance. And it in response to stress, which is really the sympathetic fight or flight nervous system, what does the RAS do? Remember, we've talked about this in the past. It promotes retention of both fluid and sodium, or sodium and then fluid is retained as well, and can cause vasoconstriction, which leads to a rise in what? Blood pressure. And remember, blood pressure is one of the primary risks for heart failure. So when the RAS system starts to go out of whack, leading to vasoconstriction and high blood pressure, you better believe that there could be a problem. However, constant activation of the RAS system, or the sympathetic nervous system in heart failure, is what really ultimately is responsible for the signs and the symptoms of heart failure that start to develop. Okay, so that's important to keep in mind. Another compensatory mechanism, is that related to the neurohormonal response. See how they call the neurohormonal response, which is the RAS system, renin-angiotensin aldosterone, is that the outcome ultimately sort of cascades into, again, same thing, further water and further sodium retention in a state or a system that is already overloaded. And what this is ultimately, the bottom line with this slide is ultimately what's going to happen, and remember we're talking about heart failure here, is there's going to be an increased workload of an already failing heart. So as that workload increases, the heart fails more. It's just the way that it does. And so you can talk about pituitary gland, and you can talk all about that, but ultimately it's that increased workload of an already failing heart due to mostly retention of water and sodium when we're talking about the RAS mechanism. Other factors that can contribute to why heart failure happens is because endothelin, which is a really strong vasoconstrictor, which is produced by the vascular endothelial cells, just like what is that amino acid? I have it in the slide. We'll get to it later. I'm blanking. So endothelial cells. So what does this endothelin do? It stimulates ADH, right? Angiotensin 2, catecholamines. Think of sympathetic nervous system. So that endothelin is still very similar to the RAS because it's going to result in what? Arterial vasoconstriction and an increase in cardiac contractility and hypertrophy. So the heart's going to have to beat harder. The heart's going to have to hypertroph, get bigger, enlarged. So the endothelin is doing nothing but, again, increasing the workload of a heart that is already failing. Cytokines is really just talking about more of a local pro-inflammatory response that's happening at the cellular level. The heart cells are releasing them in response to cardiac injury. So if they have a myocardial infarction, they're going to start to release a lot of these pro-inflammatory. And like TNF and interleukin, there's a whole bunch of interleukins, 1, 6, you name it. And they end up depressing the heart function again. And what do they cause? Same thing, hypertrophy, contractility problems, and ultimately in the long run, cell death. And so not a good thing, not a good thing to have a pro-inflammatory response in a patient who has heart failure. And I have given you at the end, I will give you some very, very detailed approaches to how to deal with this problem here that slide is talking about. We're still talking about compensatory mechanisms. We're still talking about the neurohormonal sympathetic nervous system. And again, in response to a drop in cardiac output or an inadequate stroke volume, so to say, what's going to happen? The sympathetic system is going to activate, right? The barometers are going to sense that drop in CO, cardiac output or stroke volume, and it's going to say, dude, we need to release something into the body to increase the cardiac output because we just sensed that it dropped. So what do you think they release? Catecholamines, specifically epinephrine and norepinephrine. And why do they do that? Well, to meet the drop in the cardiac output or to meet the drop in the stroke volume, right? And so these catecholamines that are going to be floating now or circulating around, the body, the blood, they're going to enhance vasoconstriction and cause heart rate. They're going to cause increase in the heart rate, right? And what do we call increased heart rate? Chronotropy. Right? Chronotropy. So generally speaking, if you end up giving a chronotropic drug to a patient that has heart failure, not necessarily a very good thing. We sometimes want to give, but we'll get into that in pharmacology. And so again, the thing to understand with compensatory mechanisms is that they may initially be good. They may initially work, right? The epinephrine and catecholamine, norepinephrine, helps increase the heart rate or helps increase the myocardial contractility. And so now cardiac output is being met. But what you must understand is that any compensatory mechanism that kicks in acutely might be good, but if it sticks to it long-term, chronically, it is not beneficial. So you cannot say compensatory mechanisms kicking in are a good thing or a bad thing. They're both. But it's a matter of timing. Compensatory mechanisms will help and be very beneficial in the beginning, at the start of them compensating. But if that compensation or the underlying problem isn't treated and that compensatory mechanism continues to have to kick in and grow and grow and grow, ultimately it's going to get to a point where it's going to be like, I'm done. I've beat it as fast as I could, as hard as I could. I've increased the contractility. Nothing has worked. And so keep in mind that over time, these factors, these mechanisms are going to be harmful and not good, as they're going to do what? Increase the workload, increase the preload, right? The volume, increase the oxygen requirement of what? An already failing heart. So when you hear heart failure, think the heart is failing for many reasons. And so the compensatory mechanisms are great in the beginning, not good in the long term. Ventricular remodeling, that's a fancy word. When you hear the word ventricular remodeling, you need to think compensatory mechanism. It's the heart that is going to change in size or shape or structure or function, or it's going to try to meet the drop in stroke volume or the drop in the cardiac output. It's going to try to change the heart to meet the demand that the body needs. And it can happen after, exercise or an injury to the heart muscle, right? So that's important too. And so hypertrophy, enlargement of the ventricles, dilating of the ventricles, and even so the cells are going to enlarge. That's what hypertrophy really means. And that's when the heart starts to thicken up. And as the ventricles become larger, guess what? They become less and less and less and less and less effective to pump out. Okay, and ventricular remodeling, this compensatory mechanism, is a major risk factor for actually a life-threatening for patients to put them into dysrhythmias and even sudden cardiac death, what we call SDC. And so with these type of patients, giving them drugs as opposed to maybe nutrients, or both can be given, but you want to do ACE inhibitors or a beta blocker, or even aldosterone antagonists, right? Try to slow down those catecholamines, slow down those that SNS. Dilation is another. It's an enlargement of the chamber of the heart. So hypertrophy is one enlargement. Dilation is another enlargement. You must think of dilation as an enlargement of the chambers. It's trying to enlarge, and this happens when there's a pressure differential or pressure change, usually in the left ventricle, or at least that's where it tends to start or is more common. Over time, the heart's going to say, dude, this is not working. This left ventricle, for one reason or another, is failing. Let's enlarge the chambers a little bit. And that ends up leading to try to compensate again for what we know: cardiac output drops, perfusion is dropping, stroke volume is dropping. And so this increased, the dilation starts pretty much it kicks in to cope with an increasing blood volume. And so eventually, over time, again, the mechanism is going to be inadequate. It's just not going to work. It'll lose elasticity. The muscle fibers lose elasticity. It becomes overstretched. It can't contract. And again, it ultimately leads to the problem that in the first place, the body's trying to kick its compensatory mechanism in, which is it sensed a drop in the cardiac output. Therefore, it's doing all of these things. Dilation is one of them. Hypertrophy is another one, right? So you can understand how understanding the compensatory mechanisms is very, very important. And so here you can see an image of the enlarged heart chambers, right? They're becoming larger in order to try to compensate for that drop in cardiac output. Hypertrophy, again, is the increase in the muscle mass, or think of it as the cardiac wall thickness, again, in response to overwork or strain, right? And this takes time for it to increase. If somebody already has cardiomegaly or hypertrophy, this didn't occur in days or weeks. It's probably been happening over months, maybe even years. Initially, the increased contractility or power of the muscle to work is going to lead to, again, that increase in cardiac output. So at the beginning, it's benign, it's good, it's wonderful, and it will maintain some tissue perfusion at the beginning. But again, over time, just like all other compensatory mechanisms, hypertrophy of the heart is going to lead to poor contractility, and it's going to require more oxygen to work harder, increased workload of the heart, and ultimately, it's going to lead to poor circulation, especially in the coronary arteries, right? Where tissues are no longer, they're going to become ischemic. And again, it puts them, hypertrophy again is going to put them at risk for dysrhythmias. No doubt, no question about it. And here, I'm going to go back to the previous image. Look at the enlarged ventricles here, right? That's dilation, which is a compensatory mechanism for heart failure. Here, look at the thickened heart muscle. And generally, that probably either or could go hand in hand with cardiomegaly. But in this case, what you're looking at here, the thickened heart muscle, is the compensatory mechanism called hypertrophy. So here you have the differentiations between both of them, right? Just to compare dilation with hypertrophy. And again, dilation is referring to the size of the filling space, the ability to fill, and hypertrophy is the thickness of the muscle. So mechanisms that you need to be aware of, and I want you to pay very close attention to BNP. It's a blood test that we know as the heart fails, BNP goes up, or as BNP goes up, we know that the heart is failing. So there is a directly inverse relationship between BNP, right? B-type natriuretic peptide. As that goes up, the heart is starting to fail. So if we use drugs or even natural therapies, and the last slide of this entire lecture is about this right here. Are there natural ways to lower the BNP? And we'll look at it, right? So really, they also used BNP to confirm the different type of functional class. They could differentiate some heart, so it really, the golden standard for heart failure, though, even though they may use it for some lung diseases, BNP is the golden lab that you need to know for heart failure. And it's a wonderful indicator for not only how bad the patient or how much risk they're at, but to see how efficacious or how good or how proper the intervention or the treatment has been. Now, normal BNP is, usually below 80. Some people say below 100. And it may be often at the beginning of the treatment may be high, right? So if a person is stable, BNP should eventually, after 6, 12 months, depending on other risk factors and how sick they are, eventually steady out. But in fact, I want you to pay attention to these words right now that I'm getting ready to say. A BNP twice or double the normal range can indicate a quadruple risk of death in people who don't even have symptoms. Let me say that again. A BNP that is double or twice the normal range. So let's say somebody who has a BNP of 200. That is seen as you have a quadruple risk of death, even in somebody who has absolutely no symptoms. So in a very, very important sense, I want you to think of this. There really is no other test that we know of that has the ability to predict, almost think of it as like having a crystal ball, right? Predict the risk of death. Or in other words, let me put it this way. With this one lab that we have the power of determining yours or my chances of having heart failure, even if you or I have no symptoms. So that's a really, really important thing to keep in mind. Now, there is a difference between ANP and BNP. We won't go into the ANP is released from the atria and BNP is released from the ventricles, but BNP is by far the most standard one that we're doing, although ANP is slowly starting to be used. And a lot of times these things are happening and being released in response to try to counteract the RAS and the sympathetic system kicking in response to try to deal with the fluid buildup, the vasodilation, and the blood pressure that is happening. Okay, so I added this image into here because nitric oxide. A lot of which L-arginine, that's what I was trying to think about. L-arginine is also produced like endothelin, which is a pro-inflammatory type thing that leads to a lot of the problems. L-arginine is one that is produced as well that is a precursor, in fact, to nitric oxide. Now, nitric oxide is hard. You really can't consume nitric oxide. It's like a gas, and it stays in your body for very short periods of time. And so we would want to consume the precursors on a regular basis, not just one time, to try to keep the nitric oxide up, and the prostaglandin as well. And they reduce oxidation, especially from that plaque buildup that we have. They reduce the release of SODs, or superoxide radicals. They reduce the multiplication of smooth muscle cells in the arterial wall. They reduce the stickiness. They prevent, therefore, formation of plaque buildup. I mean, nitric oxide, they reduce platelet stickiness. They dilate the blood vessels if there's already a big buildup in it and the blood is unable to get through. So you get the point. Nitric oxide and prostaglandins are substances that are produced in the vascular, in the endothelium, in response to, as a compensatory mechanism, activated in the heart failure. But again, we need to have the precursors for the body to be able to produce it in the first place. That's why upstream medicine, nutritional medicine, functional medicine, personalized medicine is slowly starting to say, well, maybe we do need to start to give room to CoQ10 and to L-arginine and taurine and so on and so forth, right? Because if they help the body produce that compensatory mechanism, which nitric oxide, the positive, good compensatory mechanism, then we need to think about that. And really, again, it's all about ultimately trying to maintain an adequate cardiac output to help tissue perfusion. The body has needs that, remember, what is the simplest definition of heart failure? You know, the body's inability to meet the demand, the heart's inability to meet the body's demand. And so that body's demand is to get enough perfusion, right? And so there is a little bit of a difference between compensated heart failure and decompensated heart failure. Compensated means if you have enough nutrients in your body and you're eating properly and you have a good lifestyle and you quit smoking, quit your alcohol, you have a compensated heart failure, just means that all of these compensatory mechanisms ultimately worked. They succeed in maintaining that adequate cardiac output to provide for the tissue perfusion. Now, if you have the opposite, decompensated heart failure, that happens when these mechanisms no longer can keep the cardiac output and there's an inadequate tissue perfusion. So keep that in mind. It's very important to know the difference between compensated heart failure. That means the compensatory mechanisms worked, right, and may now slowly start to go back to its norm, or they didn't work and the patient is just continually down a spiral towards where we don't want them to be. And I threw this in here because just like a lot of other things, nitric oxide is produced in the arteries, and L-arginine and I think it was the National Academy of Sciences, which used to be called the Institute of Medicine, had a couple of doctors that I listened to, and they talked about L-arginine for quite a few things: lung problems and wound healing. For wounds to heal properly, boy, the role of L-arginine is growing and growing and growing. So keep your eyes open. We're healthcare professionals, and this can not only help your patients, but it can help you and your families as well to be informed. Being informed never hurts, never hurts. All right, I'm going to take a quick sip here on my tea. I want you to look at this. These are the two classification systems. One of them you already know, the NYHA, which is 4 levels: 1, 2, 3, and 4. Fourth is being, you're having symptoms at rest. And then another way is the ACCF or the AHA stages of heart failure, and they describe it like A, B, C, or D. And D would be very similar to the NYHA stage or class 4, I should be saying. All right. And so both of them can be used as functional guidelines to to determine where the patient is at. And it's important because knowing what their class is at will allow us as nurses to determine, and the doctors to determine, what what their tolerance to physical activity is going to be. It's not the same for a person to say, "Oh, I walk around the block three times, no problem," versus I have a hard time going from the couch in my living room to the kitchen, which is about 50 steps away. Huge difference in terms of tolerance. Now, the ACCF and the AHA are really good at staging as a staging system if it's progressive, right? So patients can only really advance to higher or worse stages as as they start to as the disease progress forward. All right, so now we're moving into acute decompensated heart failure or acute heart failure. So think some people will say it's AHF, acute heart failure. The many places use ADHA, so acute decompensated, right? And we say it's acute decompensated because they're not compensated. If all of these mechanisms, compensatory mechanisms, including nitric oxide, which is a positive compensatory mechanism, start to kick in, had worked, they wouldn't have ended up in an acute stage. Therefore, in my opinion, I like acute heart failure simply because I think using the word acute and decompensated is redundant. It's sort of the same thing, in my opinion. So acute heart failure or decompensated heart failure is a sudden onset of the signs and symptoms of heart failure. Now, this is not, you don't suddenly have heart failure. It's underlying, has been going on for a long time. They either didn't know they had diabetes, they didn't know they had hypertension, or they knew and they didn't care and they didn't treat it properly. They're obese, they smoke, they eat horribly, and they drink high fructose corn syrup or Diet Coke every day. You get the point. But anyways, acute heart failure does require urgent medical care because it can lead to pulmonary or systemic congestion. And that happens again because of elevated left-sided and right-sided filling pressures, really. In other words, think about it. It's a sudden worsening of the signs and symptoms of heart failure. So if you know what the signs and symptoms of heart failure, but this happens suddenly, then we would consider it an acute reaction. And that typically includes what? Dyspnea, shortness of breath, right? Let's go over them. Leg or feet swelling. In fact, some people think that edema in the lower extremities is a hallmark or the classic sign and symptom of congestive heart failure. So leg and feet swelling. And when we discharge patients who have this problem, one of the things we teach them is, hey, if you wear your shoes today, but one day you wake up and you're unable to wear them, notify your doctor because it could mean that it's getting worse. Fatigue is a classic sign and symptom of acute heart failure. So again, in acute heart failure, you have early and later problems. The early is when clinically, it's like a mild increase in respiratory rate, and then so the oxygen or the oxygen arterial pressures are going to start to change at the beginning, right? So you'll have a slight increase in the respiratory rate. It's really later when the interstitial edema is really taking place that you start to see tachypnea, and they get pretty severely short of breath. And so if it continues, they end up going into respiratory acidemia. And one thing to think about here is if acid starts to build up, why are they going to be tachypneic? Why are they going to start to breathe fast? Because as acid builds up in the body, we know that hyperventilation, the body starts to kick into hyperventilation to get rid of CO2. And CO2 is an acid. So they want to breathe the CO2 out to try to bring that acid down. So one way to monitor our patients, if they're in the hospital with relatively stable heart failure, to see if they're worsening is to make sure that they're not starting to breathe faster, because then we may need to get some ABGs and do a few other things. So acute heart failure can manifest again as pulmonary edema. And again, it's a life-threatening situation, right? And pulmonary edema, think about the lung alveoli are now being filled up with fluid, serous fluid, sanguineous fluid. The whole interstitial area is just becoming oversaturated. And let's catch this. We had a whole lecture on coronary artery disease, and we looked at down to the cellular level at the problem that we like to say, oh, the plaque is the problem. But we actually went underneath the plaque and started looking at, well, is there enough copper in the vessel? Is there enough, what's going on at the vessel that ruptures are happening to lead to the body to have to build the plaque up? So the plaque up is not a problem. It's the body reacting to something that weakening of the endothelium vessel. Well, let me put it this way. What do you think the most common cause of pulmonary edema is? Left-sided heart failure. And what do you think the most common problem of left-sided heart failure is in the first place? Coronary artery disease. Coronary artery disease. So a lot of these people might have had coronary artery disease for 8, 9, 10, 15 years. No nurse or doctor ever talked to them about diet or lifestyle, or if they did, we didn't have time to really sit down unless they're in an outpatient setting. Hospital work is just sometimes very demanding, and unless you're discharging a patient, you don't have the luxury of communicating to your patient. But the bottom line is that coronary artery disease leads to left-sided heart failure. Left-sided heart failure leads to pulmonary edema, and that is what heart failure is. I mean, ultimately, so keep that in mind. And remember, when we think about pulmonary edema, we need to think about it as it's a progression, and why we want them to cough, turn, deep breathe, use the incentive spirometer, like actually use the incentive spirometer. It's extremely important that they do that if they have pneumonia, because that can lead them to this problem as well. So if you look at these alveolar capillary, what do they call it? Interface, where the gas oxygenation, the CO2 is kicked out. Notice how there's a red and then a blue. The red is bringing the CO2 out, and then you're going to try to hyperventilate that out through there. But remember, this area has to be working properly for you to get to get that CO2 out and bring the oxygen in. So if you look at A, there's a normal relationship between the proteins, the capillary, and the ability of the alveoli to oxygenate. Now, if you look at the B, and you look really carefully there where the arrows are pointing out, that's looking at increased pulmonary capillary pressure starting to build up, hydrostatic pressure. Remember, fluid builds up. Once fluid starts to build up, capillary or pulmonary capillary hydrostatic fluid-like pressure is going to start to build up, leading to fluid to move from the vascular space into the pulmonary interstitial space, right? Notice where it's building up, that pulmonary interstitial space in between right there. Now let's go to the third step. At this point, lymphatic flow, right, is starting to increase and unfortunately allopathic medicine still does not really take into consideration lymph drainage and lymph cleaning. They still poo-poo it. It's still non-scientific. But so let's talk about what is scientific right now. Well, in this image right here, in image C, we have lymphatic flow that is increasing. Why? Because it's attempting to pull fluid back into the vascular or into the lymphatic space. It's trying to rebalance the fluid. That's happening with the lymph system. And then finally, once you have failure of what? Of lymphatic flow, you end up having a worsening of the left heart failure, result in because of further movement of fluid into the interstitial space and into the alveoli. And at this point, even if you're tachypneic, remember hyperventilation, the body may start to kick into hyperventilation to get rid of that CO2. If you're at a level of D, that red or venous area that's bringing CO2 in, that oxygenation is not going to be able to happen. It's not going to happen. So in a nutshell, we just went through basically 4 steps of what pulmonary edema is. So it's really good to keep that in mind. So these are the clinical manifestations. I'll let you look at them. It's important to know: tachycardia, crackles, wheezes, fluid buildup. You should know this already. We've covered this in previous slides. Do go over that. This is a really good slide, and I highlighted the hemodynamic because we like to break it up into acute heart failure or decompensated heart failure into dry warm, dry cold, wet warm, or wet cold. And those are just categories that we define acute heart failures in. And we're really, when you think about dry warm, dry cold, or the most common one, wet warm or wet cold, we were thinking about hemodynamic. Clinically, are they hemodynamically stable or unstable? And it makes a huge difference, right? And so a patient that is quote unquote wet is going to be due to volume overload. And so we need to think about congestion and dyspnea, shortness of breath, right? But they may be wet because of volume overload and the congestion and they're short of breath, but they may still be warm because they have warm skin, right? Positive pulses, they're not getting pallor or blue extremities, they're still warm because there's adequate perfusion. So they're wet but still warm. So that's generally a good sign. When they start getting wet and cold, that's significantly worse than wet and warm. And again, the wet and warm is the most common one that you'll see in a lot of the patients. Now we've gone away from acute or decompensated heart failure. And I highlighted it in yellow so you know we're making a big change here. We're now changing into chronic heart failure. And chronic heart failure is really worsening of the ventricular function. And again, that whole neurohormonal RAS sympathetic system is leading to ventricular remodeling. It's just basically everything we talked about is happening just at a chronic level. And so again, remember when you hear the word ventricular remodeling, we need to think about what? It's the process where the heart is changing in its shape or size or dilating or hypertrophy, right? And so the clinical manifestations of chronic heart failure really depend on the age of the patient and what is the underlying etiology or type or how extensive the disease is, or which ventricle is failing to pump. Is it systolic and it's an ejection fraction problem, or is it diastolic and it's a filling problem? And so the Heart Failure Society of America, or HFCSA, uses FACES. And it's good for a chronic patient, how fatigued are they? What's the limitation of activities? That's the F for fatigue is AF, A for activities. Then you have chest congestion, right? Which includes cough. Then you have edema, which is the E, and then ultimately you have shortness of breath, which is S. And this really we need to use to help educate patients on identifying some of their symptoms that they may be experiencing or may get worsening over time. So again, some of the chronic heart failure manifestations are, again, fatigue, which is one of the earliest symptoms. And fatigue could be really something that we haven't caught. Something when mitochondrial dysfunction starts to happen, when ATP starts to not be produced in the amount or in the quantity, or the mitochondria now is starting to release oxidative stress, or there's a overload inflammation in the system. You may go to your doctor and get a blood draw and everything is normal, but underlying it may be a nutritional deficiency that has not been communicated with the patient. So fatigue is one of the earliest signs and symptoms. And again, it's going to be caused by a decrease in cardiac output, which is again related to impaired perfusion to the organs, right? Decreased oxygenation of the tissues, or even anemia. Don't forget anemia. Anemia sometimes can cause that problem. Renal problems, drug use always can have problems in a lot of the patients, leading to heart failure. Dyspnea is also a common manifestation, and that's going to be caused again mostly by that increased pulmonary pressure that we just talked about. Again, secondary to what? interstitial and alveolar edema. You saw the slide where it showed all four of those. That's what's happening. And so dyspnea is going to occur with mild exertion, and if it's really bad, like a class 4, dyspnea will happen even at rest. And so orthopnea is often goes hand in hand. And so we question the patient about, do you sleep with 1 pillow, 2 pillow, 3 pillow, more pillow, or do you have to sleep in a chair? Now, paroxysmal nocturnal dyspnea is basically dyspnea when the patient sleeps, right? Sometimes they wake up and they have panic. They feel like they're suffocating, or they need to sit or stand, right? And again, it's usually caused by that reabsorption of fluid in the body areas when the patient is flat. So these patients really, they won't be able to sleep flat. And then that's a good way to determine if it's PND. And then cough it goes oftentimes hand in hand with the PND, and tachycardia is also one of the early signs and symptoms to respond, right? It's the body is decompensating, so a cough in a sense is a form of compensation for a failing heart, to try to get that heart rate to activate, go up with the activation of like the sympathetic, for example, right? And so it works. Coughing sometimes help increase the CO2. Even though if it's briefly, although over time persistent tachycardia it can be harmful. So at the beginning, tachycardia, which is one of the early signs of symptom, will lead to meeting a little bit more of the cardiac output that dropped. But again, long term, it's harmful and can even exacerbate heart failure. And so we need to control that heart rate, because if we don't, they could end up having more hospitalizations, more mortality, and go into dysrhythmias. Edema and nocturia are clearly signs and symptoms. Edema, in fact, being the heart, the hallmark sign and symptom. But edema can happen not only in the lower extremities, which is peripheral edema, but also in the liver, hepatomegaly, right? Abdominal cavities, which is ascites. In the lungs, pulmonary edema or pleural effusion. We talked about that. And if they're bedridden, this puts them at really big risk for scrotal edema. And if you've never seen patients that have this problem, you'll see very, 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 very large testicles or scrotal regions. And that's a sign and symptom of heart failure happening as well. And then usually when they have edema, you want to press your fingers against the skin. And if it leads sort of a depression in it, we call it pitting edema, and that you put your finger in it, and eventually it'll go back to normal. But if it lasts 3 seconds, 2 seconds, 1 second, it doesn't matter. If it lasts any amount of time, it's still considered pitting edema. Lying flat is usually not a good thing for these people. And then nocturia also is the tendency to urinate excessively at night. And interestingly enough, chronic heart failure is frequently associated with. And why do you think that happens? Well, initially maybe when poor renal perfusion is happening, the initial reaction is to increase that peripheral or systemic edema and try to, and they urine a lot more at night. Would be because of the compensatory changes is, I guess, what I'm trying to say. It results in increased perfusion initially to the kidneys, just like at the beginning a compensatory mechanism, or tachycardia as a compensatory mechanism helps the cardiac output initially. When the fluids are reabsorbed and pushed back in and perfusion happens to the kidneys, the blood flow increases diuresis. They may urinate more and more frequently, especially throughout the night. So interestingly enough, that could be due to heart failure. With edema, weighing our patients daily is an important thing, because we want to know how much fluid they're retaining or not. This is just an image to show you pitting edema, so you can get a good idea of what it looks like. Other changes are, obviously skin changes, because if they start to appear dusky or shiny and swollen, or even diminished absent hair growth, that's a lot of the vascular problems that we'll talk about in our vascular lecture. With chronic edema, pigment changes, and it can lead to brown or browny areas in the ankles or lower. So skin can changes, behavioral changes can sometimes happen. Restlessness, confusion. They don't have the same memory span. It could be secondary again to that drop in. If you remember, heart failure is drop in CO2 in cardiac output. Sorry, and drop in perfusion. Then that poor gas exchange or perfusion to the brain, when it worsens, they start to have behavior changes as well. And this tends to be more of a late stage, by the way. If they're starting to have behavior changes, that's much more of a later one. Anxiety, depression, that can be seen as well. Chest pain can go as well hand in hand with heart failure. Angina, again, remember, if we know that coronary artery disease leads to left ventricular failure, which leads to pulmonary edema, then having heart failure is pretty much hand in hand or risk for myocardial infarction. And again, decreased cardiac output and increased myocardial work is the reason right there, right? But chest pain can accompany both acute or chronic, not only chronic. And then weight changes we've talked about that. Progressive weight gain from fluid retention. Remember, the RAS keeps the sodium, keeps the fluid in. Ultimately, fluid failure is also going to lead to fluid retention. If there's a backup from the right heart into the JVD or the liver they start getting ascites, you'll see really large ascites. That also happens to a lot of patients that have heart failure. So were they diabetic and that ended up leading to them having heart failure? Or were they first a heart failure and didn't know it and that led to the kidneys failing? It really ultimately, it's the cells are just not working as they should be working, and there may be some genetic to it, but I guarantee you, we know coronary artery disease is lifestyle. So we've got to talk to our patients about that. Pleural effusion, we talked about that. It's a common complication of heart failure, and it's basically, that the fluid buildup in that pleural area of the lungs, right? And that chest cavity, which is one reason why a lot of times they end up having some of that chest pain. Dysrhythmias, we've talked about that. Left ventricular thrombus, which could end up going into an embolism. Again, same thing, due to enlarged left ventricular, decreased cardiac output. And once that thrombus is formed, it can also, it itself can lead, it can decrease left ventricular contractility or decrease cardiac output, right? And which is going to just worsen the patient's perfusion, because thrombus means that blood is not able to get through. Hypoxemia, ischemia, and if it dislodges, it could travel to the heart, myocardial infarction, travel to the brain, thrombotic or ischemic stroke, right? We talked about hepatomegaly, we've talked about renal failure, same reasons we've talked about, right? So obviously we want to try to figure out what's going on underneath the patient. Is it anemia? Is it COPD, emphysema? Is it chronic use of drugs? Is it alcohol abuse? Is it toxins? Together with probably an inappropriate diet. I mean, any patient with chronic heart failure, we want to tell them, get rid of processed foods, get rid of sugars, and eat properly, because your cells are starving for proper nutrients. We're not saying that these lifestyle modifications, or like eating proper nutrients or CoQ10 or L-arginine, are going to be the cause for your reversal, if at all possible, of your heart failure, but they definitely play a major role in it. The science is clearly ever more pointing towards that. And so I think in this slide, one of the most important things is, just like I should have put echocardiogram in bold and red, just like I did with BNP. And the echocardiogram is one of the most valuable tests for assessing heart structure and function. Really, it's giving us information on valves, chamber size, wall thickness, contractility, relaxation, flow, pressures, volume. I mean, ejection fraction, right? Overall cardiac output as well. It's really unique in that it can look at both systolic and diastolic failure. So an echocardiogram is like the main thing to go to test for. There are other things that we can use that are here. I'm not, I'm not going to go into them. I want you to know that echocardiogram is key for the reasons that I just told you. So now we're going to go back and forth between acute heart failure into professional care, and then chronic heart failure into professional care. We're going to go back and forth between acute and chronic, acute and chronic. So the interprofessional care for acute is obviously get their vitals right. We need continuous monitoring and continuous assessment. Usually they probably will be needed to move into an acute care unit at some point if they're really decompensated, because in the ICU, we can monitor for the heart rhythm, and telemetry and progressive care units can as well. Oxygen saturation is going to have to be continuous, vital signs continuous. If you're on a floor that doesn't have it, make sure you get a machine that goes in until you can transfer the patient up if need be. Monitor for the urine output. If you have a heart failure patient and you're not looking at the kidneys, you don't understand what cardiac output decreasing and lack of renal perfusion to the organs, the vital organs, one of which is the kidneys, is. So we have to monitor that urine output every hour, right? Look at it. They're going to be monitored hemodynamically. They may need to even have an arterial blood pressure measurement. Or look at their pulmonary artery wedges and pressures to evaluate their cardiac output and their wedge pressures, because that's going to make a huge difference in how and what treatments. And one of the chapters in our book, which you'll get with Colin in chapter 64, I think it is, or 63. Is hemodynamic monitoring. That's where that goes in. So we won't go over that anymore. Some patients can stay on a step down floor or progressive care unit and may need to be put on a BiPAP for proper oxygenation. And all BiPAPs are good also in decreasing preload as well. They really work well for that as well. Get your patient into high Fowler's position, especially if they have dyspnea. Get them, the feet into horizontal bed, because positioning the patient is going to help decrease that venous return or pooling of the blood in the extremities. And also helping them into this high Fowler's position is going to increase their lung capacity, their thoracic capacity, which could help them breathe better. So we need to get them into that position. No different from if they were having a pulmonary emboli, right? So for acute, there's basically ultrafiltration or aquapheresis if there's volume overload, and that's basically removing excess of salt and water from the patient's body. In the ICU, they may use other circulatory devices like the intra-aortic balloon pump, which increases coronary blood flow to the heart muscle and decreases the workload of the heart. So that's a really good thing. So they'd have to be in a ICU for that. And the IABP, the intra-aortic balloon pump, is really all about hemodynamics, about keeping the patient stable, because ultimately we want to try to decrease that pulmonary artery pressure and decrease the systemic vascular resistance. Ultimately, if a heart is beating up against very narrow arteries because they're a smoker, have nicotine, vasoconstriction, they eat a lot of sugars and their diabetes and their blood is really thick, the heart has to work really harder against it. It's no different than the right side of the heart with the pulmonary artery pressures. And so an IABP will help decrease those pressures, which decrease workload and improve cardiac output, which is ultimately the goal that we want to achieve with heart failure. I'm not going to really go into a lot of the devices here. Other treatments, drug therapies for acute is diuretics. Obviously, if the RAS system is kicking in to hold in the fluids and the salt, that's going to overload the system with fluid, so we want to get rid of the fluid. So one way is give them diuretics. Just watch out with the potassium. And we know potassium is absolutely essential for the heart. It's so essential. So we don't want to deplete them of that either. Vasodilators, if they're really, really working against very strong increased systemic vascular resistance then we need to open their vessels up. We need to dilate those vessels to try to get that perfusion in as much as we can. And so we would use IV nitroglycerin, sodium nitroprusside, or even Natrecor as well. There are quite a few other ones that we can use, but we have to monitor their blood pressure very, very closely when we give them these medications. Morphine is really good to reduce preload and afterload. Remember, when a patient is having myocardial infarction, MONA, morphine, oxygen, nitrates, nitroglycerin, and aspirin, right? And morphine will release shortness of breath and help them breathe a little bit as well. So it's really important to give to patients that have heart failure. Positive inotrope, I want you to remember you'll be getting in third and fourth semester. Chronotrope is going to affect what? Heart rate. Chronotrope affects the heart rate. So if it has a lowering chronotropic effect, it's going to lower the heart rate. If it has an increasing chronotropic effect, it's going to increase the heart rate. Dromotropic is about the conduction of velocity, right? And then inotropic, which is in this slide, what we're looking at is really looking at the force of cardiac contraction. So these medications, so with inotropic therapy, what you think about increasing myocardial contractility. So like drugs like maybe the beta agonists that are here, dopamine, for example, or norepinephrine and whatnot, they'll be used short term, not for a long term. Milrinone is used as well as a dilator. It increases myocardial contractility. I know it has an inotropic effect as well. Same thing, right? It increases contractility. But why do we use these drugs for a short while, right? They may help a little bit with peripheral vasodilation and things of that nature. But all these drugs are doing is the same thing as the body already naturally does in itself when it kicks in a compensatory mechanism. So these may be good short term, but if you use them long enough, they become chronic and no longer work. Digitalis is one of the big ones that we can use. It has really, really good, powerful, positive inotrope. So positive inotrope. Inotrope does what? Force of cardiac contractility, because it's a positive inotrope. It increases, it improves left ventricular function. It helps that ejection fraction to happen. It increases, digitalis will help with the contractility, right? That's what we want to get that myocardial oxygen and perfusion. But it's tricky because you have to measure it, and there has to be a loading dose. And potassium, you got to make sure that the patient has enough potassium if you're giving them this type of this medication, because otherwise you can cause some complications. Now we're going to professional care for chronic heart failure. I'm not going to repeat this. The main goal for all heart failure, right, is to treat the underlying cause, try to solve for the problem, maximize cardiac output, reduce the symptoms. So if they're having breathing symptoms, maybe an inhaler. If they're having pain, maybe some morphine or some medication. We want to try to improve their ventricular function, overall improve their quality of life, try to preserve target function, make sure the kidneys are able to work, the liver as well, and hopefully try to improve mortality and morbidity risks over and beyond that. So that's what we need to do. Further approaches is we want to relieve the dyspnea and fatigue. So we want to bring that oxygen saturation up so we can, because one of the problems with heart failure again is that reduced oxygenation. It's not adequate perfusion in the lungs. So we got to make sure we boost their oxygen up to improve that saturation and help meet the tissue oxygenation needs. We rest them for physical, emotional rest to try to de-stress them. If they have a job or a work that puts them at stress, tell them that it would help them, if at all possible, to get into a position that might not be as stressful, if he can at all transfer or she can at all transfer within the hospital, within their job, and then we have to talk to them about, participating in activities based on their, their ability to, how much you, so we have to assess for their baseline. What could you do before you started having this problem? How long ago were you able to walk around the block? And, oh, so now you can't walk around the block 3 times? How many times? Only half a time. Oh, okay. So those are good ways to monitor and look out for that. And so cardiac rehabilitation, which is what CR means, is also associated with better outcomes, and it just and even less depression as well. It gets them active, it gets their blood flowing. But if we don't talk to them about lifestyle, it's going to be really tricky. A chronic heart failure interprofessional. The CardioMEMS is sort of a monitor. I'm not very familiar with it. I think it's monitoring pulmonary pressures, and it's a permanent device that goes into the patient. In this slide, just remember that patients that have an EF of less than 30, 35, there are very high increased risk for sudden cardiac death, mostly from VTAC or VFib. Remember, VTAC and VFib are the big no-nos. You'll get that as you go through, mostly the ventricular problems. And so with these patients, an ICD, which is much more common than a CardioMEMS, would be recommended. You'll get a lot of patients in your hospitals that have ICDs. And I briefly talked earlier about an intra-arterial balloon pump. And there's limitations to that, but in the hospital, sometimes they need to have it. Pacemakers in some cases to resynchronize, maybe. Diuretics, we talked about them. Monitor potassium levels, always monitor potassium levels, right? And remember, diuretics are just trying to reduce that pulmonary edema, reduce the edema in the legs, reduce the edema no matter where it is. And so that diuretics play a major role. The RAS inhibitors, I always like to say that, hey, if you're leaving the hospital, you're discharging the patient, they're relatively stable, things like hawthorn, which we've talked a lot about, garlic, calcium if it has magnesium and vitamin D with it, fish oil, the omega-3 especially, are very helpful, and they're natural forms of ACE inhibitors, right? Now, most patients will be put on an ACE inhibitor from like a drug in the hospital, or even when they go out, and it's one of the best or primary drug of choice for blocking the RAS. But remember, the RAS is a sympathetic reaction, so magnesium, for example, is very, very good at working at it. Angiotensin II are for patients who are unable to tolerate ACE inhibitors. They may need a angiotensin II receptor blocker. And then you have the aldosterone antagonists. Aldactone, spironolactone, for example, are used quite a bit. But just remember, the aldosterone antagonists like aldosterone is good for patients who have long-term heart failure and reduced ejection fraction. It can help them. We need to tell them about diet and eating as well, and just watch out with that potassium. So the beta blockers, again, they block the sympathetic nervous system, right? So they instead of the sympathetic wants to increase the heart rate, you give a beta blocker, decrease the heart rate, you're allowing the heart to rest, right? Remember, the heart is already failing. Vasodilators like nitrates cause vasodilation. They directly act on the smooth muscle, on the vessel wall, right? And nitrates are really, really beneficial with MI type patients, the patients that have HF that go into an MI, because they dilate the coronary arteries as well. The Bidil is a combination therapy, hydralazine with isosorbide. Is really good in mostly African Americans that have heart failure, that are getting good therapy with ACE inhibitors and beta blockers. They may add that on top of it if they start to go downhill and the first two didn't work. The same combination or benefit is not found in Caucasians, by the way. And then the positive inotropes, we talked about them, is digitalis, and that increases digoxin, for example, is one example. It increases the force of the cardiac contraction, which is what a positive inotropic reaction does. Another drug, not that common, Corlinor. You must be in sinus rhythm. There's certain conditions. Just read the MAR. Make sure you follow the instructions that when you go to give this medication properly. Um, I love that the two only slides that they give you to nutritional therapy, one just says limit your salt intake, and yeah, that will. The reason why they say limit your salt intake is because while you're in the active, when the RAS is kicked in, renin, angiotensin, aldosterone system is kicked in, it's withholding sodium, withholding fluids, and so your sodium is starting to be withheld. So we say withhold your sodium. Well, what happens when their RAS goes back to homeostatic? It's not kicked in. They're not taking sodium, and now we told them to withhold their sodium. A lot of elderly people are coming into the hospital with hyponatremia, so we have to be careful. And there is some data that's starting to come out to show that there's not, there's not that much data to say that a low sodium is that beneficial. But we definitely want to tell them don't overload with sodium. Don't be adding more sodium to it. The DASH diet is clearly very good for the hypertension, and no more than 2,000 milligrams of sodium a day. All right, so this is a second slide, which is funny because it's supposed to be a nutritional therapy approach, and all it tells you is some patients that have all that congestive, they're very wet, need to have fluid restriction. It's not generally required, but if so, the doctor will indicate no more than 2 liters or no more than 1.5 liters a day, or if they're really severe, their ejection fraction is like 15%, they may need to be no more than 1 liter, right? So they may be able to have ice chips, gum, something in their mouth, but not drinking fluid. And then we have to weigh them daily, and so that's our nutritional therapy: is weigh them, watch out with their fluids, tell them not to have salt, and that's it, people. Not true. I will give you a few more things that are coming out as evidence closer to the end, which is not too far from now. This one is just looking at subjective data, like all patients get a past history of family and personal for any heart problems, and what are they on any drugs, right? And what is their compliance? Are they taking their medications? So we have to carefully do a good med rec to make sure we're on page with them. We need to obtain certain information, health-related information as to their functional health patterns. How do they perceive themselves, their health perception, like fatigue, depression, anxiety, their nutritional or metabolic approach. So of course, sodium intake is one that they always talk about. Nausea, vomiting, bloating, weight gain, ankle swelling. Those just go hand in hand. Nocturia, we already talked a little bit about. That's part of the elimination. And also, if decreased urine output, that starts to indicate that there's a lack of perfusion to the lung, to the kidneys. Activity exercise is what the dyspnea, orthopnea, or cough is about. So how many pillows do you sleep with? Number of pillows that you use to sleep with will indicate the severity. We need to ask about, do they wake up in the morning with sort of a panic type situation, or are they having insomnia, right? Unable to sleep. Right upper pain quadrant, abdominal discomfort. Remember, right upper quad, what organ is there? The liver. That could be indicative of issues going on in the heart, such as heart failure, right? Again, the integumentary, whether they're cool, clammy, diaphoretic, cyanosis pallor, or if they're warm, that could indicate right side heart issues. Respiratory system, when you go down it, just think tachypnea, crackles, rhonchi, wheezes, froth, blood-tinged sputum, things like that. Cardiovascular, make sure they have the typical S1, S2. You don't want them to tachycardia too long. You don't want them to have S3, S4. Monitor for murmurs. Monitor for display for the heart. If there's cardiomegaly, make sure that point of maximal intensity is close to the 5th, not the 6th intercostal space on the left chest. Also monitor for jugular vein distension. Again, gastrointestinally, we're going to look at their abdominal distension, hepatosplenomegaly, ascites for sure. Neurologically, then changes in levels of consciousness, and that just means restlessness, confusion, decreased attention, or memory. And so Some of the objective things we'll do is we'll look for the sodium and potassium for sure. We'll look at their increased BUN to see if it's getting worse, like creatinine. We'll look at their liver function tests for sure. We're going to look at their BNP. We'll do a chest rate. We'll look at cardiomegaly to see if there's pulmonary congestion or even interstitial fluid backup. And then we'll echocardiogram, ECG, O2 sats. These are some of the nursing diagnosis. You can imagine why: increased gas exchange, decreased cardiac output, excess fluid volume, and activity intolerance, all due to what we've been talking about. Overall goals: just try to decrease symptoms, decrease peripheral edema, increase exercise tolerance, to have them walk a little bit more than they were able to. That's a good sign. If they're walking less than they were able to, that's a bad sign. And then keep them compliant with their treatment. And try to make sure they don't have complications. Health promotion, I'm going to really talk about what health promotion is in just a second here. And again, heart failure is a progressive. SALT, conserve energy, maintain support systems in your family. These are all things that we have to monitor on a regular basis. And we've talked about all of them as we go through this lecture. INO for the kidneys, respiratory status, right? Semi-foulers or raise them into high foulers, we have to monitor their hemodynamic status. I could go into a lot of these, but in fact, a lot of them I have gone into as we go through, as I've talked through this lecture. So alternate rest with activity. Tell them to not exercise too much all at once. Keep them distracted. Monitor response to activity. Have them write it down. Work with OT and PT. Reduce anxiety or stress in your life, because stress is what leads your heart to have to work overtime anyways. And then look and see, make sure you have family, friends that you can live with, or that'll be at your side. And then we have to learn about patient teaching. Ambulatory care, will explain what could change and how the patient is going to react to the changes that heart failure lead to, in his ability to breathe and walk and ambulate, and then how the patient is going to respond to these. To having heart failure. So we have to teach them the signs and symptoms of heart failure and what to do and report. Not like shoes don't fit anymore, increase shortness of breath, increase intolerance of activity. These are all things we can teach them to detect early, and will have an ultimate positive outlook on preventing the patient from getting from having the heart failure getting worse. The drug therapy, what to expect to increase of feeling better, breathing better, walking more. Talk about the beta blockers, the heart rate, what we got to monitor, make sure that there are, not too low. Some patients with heart failure will still give beta blockers even if their heart rate is 50 or 55. But if you're in the hospital, the MAR has to have that parameter written in. Otherwise, if it's a beta blocker and their heart rate's below 60, we need to call the doctor up and say, hey, is there a parameter you want us to put into the MAR with these medications? And we need to monitor their electrolytes, especially potassium and sodium, and then monitor their blood pressure as well. Dietary therapy, I'm going to say a lot more than just that. Smaller, more frequent meals just conserves their energy, and remember, conserving energy is important. Like having a fever uses more oxygen. There's more oxygen demand, so eating big meals, the same thing. Eating small meals, less. So it makes sense, right? Daily weights, read labels for sodium, read labels for a whole lot more, and then have a written plan as well, and we'll get into that. Activity rest, we've talked about that. Go back and forth between exercise and rest and exercise. Increase things gradually. Try to avoid extremity in terms of temperatures, heat and cold. And every time you feel exertion, make sure you sit down. Know your faces. Teach your patient the faces. Remember that? What were they? Let me see if I can get them. Fatigue. Activities, how much activity or limit activity you can. Chest congestion or pain or cough, edema, and shortness of breath, right? So those are things you want to do. Weigh the patient, regular follow-up, support group, get your vaccinations, and reduce risk factors, smoking, weight gain, blood pressure control. We're going to always monitor their vital signs, weight, pulse ox, and dyspnea. Home health nurse can be essential for them as well. And in some patients, they may go home with some electronic monitoring devices, and you'll get that as you go through. I'm not going to cover any of the devices. This is the only slide that I have on the heart transplant. There's only about 2,000 hearts available. Usually, on average, there's about 3,000 people on the list. It's a very strict selection process that they have to go through and working, and they have to be determined to. There's a lot of physical, diagnostic, and psychological evaluation. If they're alcoholics or drug users and they're positive, they're clearly not going to get a heart. Somebody who is going to go back to taking drugs is considered not worthy, so they would have to go through detoxification therapy first. I'm going to let you guys go through these right here and determine what the right answer is for these, okay? And then, because I want to run really quickly to the last few. So drugs are great, but they're not without risks. And especially potassium, magnesium, most diuretics deplete you of more than just potassium. And so we know that genes play a role, lifestyle play a role, diet play a role, toxins may play a role, especially in hypertension, right? So if you look at the bottom left, CoQ10, and I'll show you a study and I'll give you the reference to it, at the mitochondrial level, if you feed the cell with CoQ10, magnesium, L-carnitine, they will allow the body to work better. If you look at a 20-year-old versus a 40-year-old versus an 80-year-old, you'll notice that the tissue in the body that has an age-related decrease in a ubiquinol or ubiquinone is the heart. And so Dr. Sinatra is a doctor who works a lot with heart, with CoQ10, and so it's been shown to work at the cellular level to help with energy production. And so this is just a repeat of the previous slide that shows you how over time, as you become older, you go from having 100% of CoQ10 in your mitochondria at the tissue level, tissue saturation of mitochondria, down to having 42%. So you have less than 50%. And so I threw this slide in here to show you that, if you supplement it, ubiquinol, at an early age, this decline can be slowed, and a person can end up being 80 years old and still having significant levels of ubiquinone in the body. And so why is providing proper nutrients to the body important? Because we know that mitochondrial dysfunction leads to, look at the bottom right there, enhancements of insulin resistance, which leads to diabetes, obesity, and chronic heart failure. So we know that mitochondrial dysfunction is linked to a series of problems: oxidative stress and increased reactive species production, but also congestive heart failure. And so we know that the mitochondria is the powerhouse. It helps with DNA production, helps with ATP, and it maintains the cell electrochemical integrity, right? And so a good cell and a bad mitochondria, this is what they would look like. You've seen this before. And one good cell is able to produce lots of energy, and therefore the heart will have lots of energy and few free radicals, versus one that is unable to produce energy properly, ATP, and is producing tremendous amount, just flowing, overloading your blood stream with free radicals. And tobacco is one of the worst free radicals you can have. So a major breakthrough in heart failure research has shown that it can significantly improve survival in patients that have even severe class 3 or 4 heart failure and dramatically reduce hospitalization. So even taking up to 100 milligrams of CoQ10, now we'll tell you there's a huge debate out there about which form of CoQ10 is more absorbable. Is it ubiquinol? Is it ubiquinone? I'm not going to even go into this. If you're interested, look into it, but there is research that shows that there is a significant help and assistance to the heart with that. Other root causes, if you have elevated homocysteine, we already know what that is. We've talked about that in previous classes. Insufficient or low vitamin D.
They'll tell you if you have a vitamin D of 25 or of 30, or if you're like right above that 30. Let's say you have 31. Oh, your vitamin D is normal. Well, we really want to push it to closer to 40 or 50, which not many people have. And some people have said that this deadly oversight of just this hormone imbalance, lack of nutrients, or even having an excess homocysteine is a big problem that is leading to a lot of Americans having a lot of the heart failure. This slide from SpectraCell Labs, I like them because it sort of shows you that a lot of these things, ideally we get them from food, but they're based on some scientific evidence that show that all of these things in deficiency can lead to increasing cellular mitochondrial inflammation reaction, which is not a good thing. Other natural approaches is consume antioxidant-rich foods. Try to look and determine if you have heavy metal toxicity, if it's burdened into your condition. Try to control chronic alcohol consumption, reduce oxidative stress and aging. All of these things help. And of course, stop smoking if you smoke, exercise more, monitor your sodium intake, okay? According to the Orthomolecular website, which I love, 2 vitamin C tablets a day could save 200,000 lives. That's super cheap, right? And it shows that the research from 2011 that the risk to heart failure decreases as your blood level vitamin C goes up. So that means persons with the highest level of vitamin C had the lowest risk of heart failure. So think about that. Now down below all the way at the end, if you increase plasma vitamin C, even in a small amount, right? So you could give vitamin C IV in high doses, but even a small amount of vitamin C helps the body as well. So in order to achieve a plasma level of 80, and thereby reducing deaths of up to 260,000 per year, just an average daily dose of 500 milligrams a day. A lot of people take 3,000 to 8,000 per day without any problems. But generally speaking, you take a lot of vitamin C until you start having really loose stools, and then you back up a little bit, and it's a relatively safe thing. It's a harmless thing to introduce into your body. Now, there are some things to consider. We won't go into that, but vitamin C has been linked to being protective. Here's the link to that for patients that have cancer or even heart failure. And if you go to a doctor who is still very knowledgeable and able to give you ACE inhibitors and know when to send you to the surgeon or into the hospital because you're having an acute episode, then we wouldn't be using something like this. But if you're a patient who's still relatively able-bodied, pretty with it, then maybe if you have a systolic failure, you would take some L-carnitine, some taurine, magnesium, some hawthorn, get a B complex. Make sure you get a good multi-mineral and a multivitamin and a multi-mineral. And if you have a diastolic, you could do turmeric, you could do digestive enzymes, get that vitamin C, do a fish oil like omega-3, the EPA and the DHA. So this is just an example of what one provider might want to provide to a patient to help the heart work properly. So drugs are not the only way we can approach the therapy. So this is the last slide, and I do apologize. I will go back and look at those 2 exam questions. I just wanted to get through this because last time my recording level stopped automatically, and I wanted to at least cover all the grounds. I think we're going to be okay, so I will go back and look at those questions. So how do we treat an elevated BNP? So if we know that the #1 lab that is directly related to correlated to heart failure. So as BNP goes up, right, your heart fails and fails more, directly related. So there's evidence out there that says that if we consume 8 forms of vitamin E, the real vitamin E, the 4 tocopherols and tocotrienols, then the tocotrienols are the precursors to the natriuretic hormone, which is what BNP is in the first place. And of course, these tocotrienols are an essential part of what the body uses to make BNP in the first place to help heal the heart. So if you don't have enough of these in the first place, then well, go figure, right? So the first thing is to make sure you have good levels of the 8 forms of vitamin E and B and P. And this is not new. We've known this for quite a thing. I mean, it's a sad thing that a lot of cardiologists or doctors aren't working with this, but the evidence is out there. There's good data that shows that vitamin E is safe to take, and we can use it. We can use it. Absolutely use it. So let's go back, because I think, yeah, that was the last slide. So let me go back to the 2 questions and 3 questions. Okay, so I'm going to let you read that and take a quick sip here of my tea.